Bismillahirrahmanirrahim. Assalamu alaikum warahmatullah. So, there you go. So the topic is not intended to scare everybody. Heart failure sounds scary, but I'll keep it very, very basic so that just the audience has an understanding by the end of the talk as to what congestive heart failure is all about. So this is just for maybe the doctors here also, just give you a little case scenario. 65-year-old female with history of obesity, sleep apnea, hypertension, presents with shortness of breath, lower extremity edema, weight gain, heart sounds are distant, JVP is elevated, basal rails are audible, BNP is elevated, echocardiogram shows an EF of 55%, no valves. What is the diagnosis? So those who just some alphabet jargon for physicians, HFpEF, HFrEF, HFMREF, or HF improved EF. You can think about what it is in your mind, and I'll show you in a second what this is. So then, same patient, what would you call it? This is a stage A, B, C, or D of congestive heart failure. Interest of time, I'm not going to show of hands, but maybe the next question. And same patient again. What's the class? New York Heart Association class of heart failure. Is it 1, 2, 3, or 4? On this, we can have a show of hands. Again, doctors only, not everybody, because this is, so is it class 1, 2, 3, okay, and 4? All right. So again, let's see, we'll explain what all this is about. So, oops. This is the definition, and this is where everybody can be helped. So clinical syndrome with symptoms and or signs caused by structural and or functional cardiac abnormality and corroborated by elevated natriuretic peptide, or we call BNP levels, and or objective evidence of pulmonary or systemic congestion. So lots of words in this, but basically heart is a pump, as we know. When the pump doesn't function well, sometimes the pump may be structurally normal, but functionally abnormal. So you may see that the heart is squeezing okay, but not relaxing all that well. So, or the heart pump is good, but the valves are not working well. Or the pump is good, but the electrical wiring and cabling is not working well. So all of those, when the heart's function, where there are symptoms and or signs caused by structural functional cardiac abnormality. So whenever there is malfunction of the pump, it's called congestive heart failure. It's a broad term with many, many different syndromes in there. Now, the common concept of failure that, oh, he had heart failure and he died, that's not the heart failure medically speaking. That's actually cardiac arrest. When someone has bad rhythm in the heart and the heart stops and the person dies, that's not congestive heart failure, but that's cardiac arrest. So this is a definition which has everything in its scope. One thing I must say for our audience is that one aspect of heart failure where the relaxation is a problem, and I'm talking about layman terms, where the heart contracts well but doesn't relax well, it can happen to all of us as we grow older. And one of the things that we have learned that fights that is activity or exercise. So the more you're active, the less likely you would be to develop that type of heart failure. So it's better to use it or lose it. So use your heart, be active, exercise, so that your heart remains fit and healthy. Otherwise, if you don't use it, it'll become short and small and stiff, and it won't be working well. So I mentioned earlier the stages of heart failure. So these are the stages, just so people know, stage A, B, C, or D. So stage A is where someone is at risk for developing heart failure, meaning they have hypertension or some sort of valve disease that have no signs or symptoms of congestive heart failure. For those who are not medical, symptoms are what the patient tells you, that I'm feeling short of breath or I'm having chest pain. Sign is when you examine the patient and you see something. For example, you auscultate and you hear some crackles or rumbling, or you look at the neck and you see the neck venous distension, or you touch some area and it's tender to touch. Those are signs. And symptoms are when some patient will tell you. So when we're documenting the history, we would say, okay, fine, the patient came in with these symptoms, and when I examined the patient, those were the signs. So in stage A of heart failure, there are risks of developing heart failure: obesity, sleep apnea, left ventricular hypertrophy, hypertension for whatever reason. And stage B is now where structural abnormality is developing. Patient is still not symptomatic. Symptomatic in most clinical definitions is stage C of different aspects where structural abnormality has taken place, but now the patient has symptoms. For example, if someone has a valve narrowing and they have no symptoms whatsoever, and they may be stage B. Things are happening inside, no one knows, patient doesn't know, doctor hasn't looked. Stage C is when there is symptomatic heart failure, meaning now the person is complaining of symptoms and they have structural problem. The heart muscle is weak. Normal heart pumps about 55% of its blood, 55 to 65, 70% of its blood, not 100%. So if someone has, the pump is only doing 35%, initially they were asymptomatic, then they develop symptoms, that's stage C, and stage D is advanced heart failure when they are symptomatic, sometimes at rest, they come to the hospital, they need treatment. So remember our patients who was coming in with symptomatic heart failure, so that was stage C. This is the functional classification, and you'll hear a lot about both clinicians and non-clinicians. And this is used in anginal class, heart failure class, a somewhat similar concept. And it's easy to look at class 1 and class 4 is easy to know. Class 1 is practically asymptomatic person. So they may have the syndrome, may have the condition, but they have no symptoms. They feel fine. Or class 4, when they are symptomatic at rest, meaning they can't talk to you without getting short of breath. They can't eat without getting short of breath. So that is class 4. And class 2 or 3 in the middle. Class 2 is when someone becomes symptomatic with significant activity, climbing up a couple of flights of steps, and then you get short of breath. And class 3 is when you walk from your room to your bathroom, you have shortness of breath. So that's 3. So we use these classifications so we can gauge and we can correlate with or tell other partners, okay, the person came in and was in class 3. So my fellow partner or whoever would know what sort of symptoms the person has. So this classification, this is functional classification. So they're all different classifications that we use in all disease entities just so that we can communicate with each other, we can understand the state of the disease and progress, gauge progress, and whether or not we have made an impact on the patient. Dr. Saab, you can have this time, so I can cut whenever you want. So this is where I also said alphabet jargon that we use a lot. So I mentioned the heart is a pump. 1 minute. The heart is a pump, and I think we'll end with this concept, is that normally heart pumps about 55% of its blood. So if it has 100 cc's, it will pump 55. If that pump is weaker and it's doing less than 40%, it's heart failure with reduced ejection fraction. If it's over 50%, it's heart failure with preserved ejection fraction. If it's between 40 and 50, it's heart failure with mildly reduced ejection fraction. And then sometimes the heart recovers with treatment. Then we say, well, it's heart failure, but improved ejection fraction. So there are many, many different classifications you can use. And then this is the diagram to go over the treatment, which can be complex, but there are many different life-saving treatment options that are available that we should, as prescribers, should all be prescribing. You know about diuretics, beta blockers, different classes of medications. And the last comment I would make is that as a physician, we have to be sure that we talk about not just pills, but lifestyle. And this is something we're learning, that as a doctor, it's easy to write a prescription, but more difficult to sit and talk and discuss with the patient. But I think we need to invest more time and energy about talking about their life, their routines, their diet, their exercise, physical activities, and other things, because that have a strong impact in all medical conditions. So I think we'll have more and more focus on lifestyle in the future along with medications. Thank you for your attention.